Time flies when you're having fun, and now it is day 2 here at TCT 2015 for On the Scene. I'm Peter Block, and with me is Deepak Bhatt. And day 2 highlighted a couple of things about ST elevation myocardial infarction, Deepak. The whole issue of whether or not you should aspirate thrombus, and the whole issue of whether or not you should or should not do some other things with ST elevation MI. So let's talk about aspiration first.
Sure, so more data from the total trial, 1-year results, and basically the message is staying the same. Really no obvious benefit for routine thrombus aspiration in STEMI, despite its intuitive appeal.
I mean, it makes a lot of sense if you have an artery filled with thrombus and you think getting it out, but in fact, stroke rates were higher early, and at 1 year there was no difference in stroke rates as time went on. No surprise, I think. But at the front end, it probably isn't so great for you. The question I had is, what is the role of thrombus aspiration in ST elevation MI? And I think the only real answer is if you have an artery that's just filled with thrombus and you can't open it with a balloon, maybe trying to get it open with a thrombectomy catheter is appropriate. Would you agree?
Yeah, I'd agree. I mean, I think as a routine strategy, you can't really endorse something that costs money and is associated with a higher rate of stroke, you know. But I think selective use at times, really bailout use, I think there's still a role. When I say selective, I shouldn't have said selective, because there's no data from total that supports that if you have a bigger thrombus, you know, then there was some benefit. So it actually wouldn't even be selective use. It would only be bailout use that I think can be justified.
Okay, so the other issue with myocardial infarction patients, of course, is after you do the infarct artery, and now you have a CTO on the other side, what do you do about the CTO?
Yeah, well, you know, typically I would have left it alone, but what these investigators asked, which is a legitimate question, is in that patient that just had the STEMI, would there be some benefit in terms of their ejection fraction in 4 months or so on MR by opening up that CTO in the next week or so after the STEMI?
Yeah, this is the Explorer trial, and doesn't make any difference.
No improvement in EF, and the study was too small to look at clinical endpoints. So in terms of endorsing it as a strategy, really there's no basis to, if the goal is to improve EF. Now in somebody that has a STEMI, you open up their culprit artery, and they're having angina from a CTO, you know, that's a different story. If they've got bad angina, medical therapy can't handle it, sure, go after the CTO. But as a routine strategy to improve EF, don't do it.
And that's sort of an intriguing endpoint that they chose for this trial, the ejection fraction improvement, which did not improve. You would think that probably if there are collaterals, it's not going to make that much difference to EF. Maybe to angina, but not EF, and in fact that's what they showed.
Absolutely. To resting EF in particular, why should that change? But you made a good point, just that, you know, this is different from some of the other studies that have looked at multi-vessel PCI in STEMI that excluded CTO patients, so those patients weren't in there.
All right, so let's move on to the whole business of how do you take care of patients who have symptoms of ischemia after a PCI, the RIVER PCI trial, ranolazine given after PCI randomized yes or no. Outcomes of that also not very impressive.
Yeah, I mean, there was no difference at all in terms of positive outcomes. Nothing was in favor of ranolazine, which perhaps is a bit surprising because at least when I've used it, not in this broad population, but selectively in folks with really bad angina, it does seem to provide angina relief. But here in a broad all-comers population where they got PCI but then still had angina, really didn't have any benefit on any of the endpoints that were examined. A couple of things even went in the wrong direction, TIA, heart failure, though small number of events.
Not sure why that should happen, but a lot of patients also couldn't finish the ranolazine, so that may have had some effect.
Well, see, that's a good point. So there was more discontinuation of study drug of the ranolazine than placebo. So, you know, maybe it's the folks, I didn't actually see an on-treatment analysis. It might be in the paper, I didn't get to read it, but maybe the folks that were able to stay on it derived more benefit. But certainly in the overall trial, it seemed pretty negative.
Ranolazine's a funny drug. I've used it a lot in patients where I had no other options. It seems to me, and I may get in trouble for saying this, some patients do better on it than you would expect, and other patients don't do so better on it.
Well, you know, I think it's a tough population because where you and I use it are folks with refractory angina, no revasc options, and you've got to do something. It's hard to know. Sometimes there's a bit of a placebo effect there too, so it could be a little bit of that sometimes as well. But even discounting that, other studies have shown that it does have effects on improving angina. So I think what this trial shows is it's not a drug that should be used broadly for angina relief or prophylactically, but I don't think it discounts its selective use in those really refractory angina patients.
Like everything else that we do, a little judgment is probably a useful thing in this one. So there you
Absolutely.
have day 2, mostly involved with ST elevation myocardial infarction and how to deal with coronary insufficiency after PCI. Thanks, Deepak.
Thank you.